So speaking of health insurance, um, I want to talk a little bit about Luigi Mangione, the heartthrob, healthcare CEO murderer. So, you've been covering healthcare for a long time. You wrote a lot about Obamacare. I think this has been, from my perception, kind of one of the top 5 areas of focus for you over the years. I would say.
Definitely.
So, I think it goes without saying, and I'm gonna, having read you a long time, I'm gonna predict you are anti-murder. So we don't have to litigate
Don't
that.
try to put me in a box. I contain multitudes. Yes, I'm anti-murder.
But if we were to just take Luigi Mangione's diagnosis, such as it is, of the problems with the American healthcare system, as explained in his manifesto, his choice to target an insurance CEO as opposed to, say, a big pharma CEO or the leader of a network of hospitals, or any number of potential targets, he quite specifically chose a health insurance CEO and diagnosed the deepest problem with the cost of healthcare as lying with the bean counting insurance companies that are okay denying you coverage and making the whole system confusing enough that people can really get hit with surprising bills in difficult situations and so forth. To what extent is that diagnosis analytically correct?
Well, let me say this, right? There's another concept in economics called principal agent problems, which is where you do not have the same incentives as people working for you. And what you have in the healthcare system, because the way we pay for it is so weird and diffuse, is that you don't have these same incentives as the other people in the system, right? For me, I want unlimited care, the best possible. I want to have the best possible doctor. I want to have any possible treatment that could conceivably help me. That's not, no one Warren Buffett can afford to have that, but that's not practical. You can't have everyone getting every single thing they might conceivably want. And that is true, to be clear, in every system in the world. In fact, the United States is bad at rationing. It's not good at rationing. We are not good at denying people treatments. We probably overtreat people, and I don't mean this in terms of cost. We're a rich country. We can basically afford what we're doing. But, for example, end of life is somewhere where you see this a lot. And I think the statistic that we spend too much at the end of life is a little, people will say, well, 25 or 50% of spending is in the last year of life. And that's true, but you don't know it's the last year of life. My mother went from she had COPD, so she was not healthy, but there was no reason to think that she was going to die imminently. And 6 weeks later, she was dead after a series of incredibly expensive hospital stays. Mm-hmm. And that's just something that it happens. People destabilize. You spend a tremendous amount of money. But we do a lot of treatments that are probably marginal, that it's not clear that there's a huge benefit to them. And of course, there's a cost. And I think you see this with cancer patients, where doctors actually will often choose different things than what most patients do, because doctors don't want to tell people it's time to give up.
Right.
They're reluctant to say that. And the doctors, when they get cancer, it's not that they don't keep trying, they do, but they recognize earlier that it's time to stop. Mm-hmm. Because they're trying to save the system money, because they see that at some margin doing these highly speculative, this probably won't work, but why not give it a go for $500,000 or whatever, these treatments have side effects and they're quite severe, and they just decide not to pursue every last possibility. But we want the option to pursue every last possibility. No system can provide that. And the insurer in America is the place that makes that clear. That it's not just between you and your doctor, because you're not paying for it. If you're paying for it in plastic surgery, it's also actually not just between you and your doctor. Plastic surgeons worry a lot about the problem of people who have body dysmorphic disorder and will just keep getting surgeries that, in the judgment of everyone who is not that person, are not helping them and are in fact harming them, because they will never get over their belief that they're not right, and they will destroy their body trying to fiddle with it. But it is more true in plastic surgery that it's between you and your doctor. You're paying for it. And so you can decide whether you want to have enormous breasts or liposuction or whatever, and it's no one else's business. But when someone else is paying for it, it's their business. And what I think is, what you see in the healthcare system, interestingly, is everyone who's not a wonk, who doesn't study this issue, they're all convinced that the two evil actors in this are the insurance companies and pharma. And in fact, pharma is probably saving us money on net. They are saving us from having surgeries, which are usually worse than drugs. Not always. Sometimes you decide take care of the problem for good, but drugs can prevent a lot of things. They prevent strokes. They prevent cardiovascular, right? It's much cheaper and better for everyone if you take your hypertension meds rather than having a stroke. But unlike a lot of other things in the system, that's the place where consumers are most consistently reminded that they are paying for this, right? Every month, you got to go fill the bottle. Insurers, similarly, are where people see that there are things that they maybe want to do and they're not being allowed to do. And in fact, that's not what's driving the cost. The insurers are holding down the cost, right? That's their job in the system. And in fact, I think a lot of people aren't aware, they're regulated. They can't, when they deny claims, that's saving money for the claims holders. They can't make more profit that way. In fact, they make less profit because they have something called a medical loss ratio, really, wonky term. Basically what it means is they have to pay out a certain amount of their premiums and claims. And it is somewhere between 80 and 85%, depending on the size of the company, the size of the insurer. But basically, and then the rest goes to overhead, and then there's actually a quite small profit. It's not a very profitable industry. Mm-hmm. And so they don't make money by denying you claims. What they do is hold premiums down by denying you claims. And that has to happen. Britain does it. Every system does it. But what's different is that in the US, it's transparent. And this is because our system's so fragmented. There are so many different insurers. They each negotiate different deals with doctors and hospitals and all the rest of it. So your doctor, when he's talking about treatment with you, does not know whether it's covered or not.
Right.
Now, if you're in the NHS, that doctor knows whether it's covered. They don't tell you about things that aren't covered. You never hear about it. You're just told this is what we do. And so I'm at Kaiser, which is the closest thing that the United States has to the NHS. And that's my experience. They just tell me what I'm going to do and then I do it. Now, I have a lot of external resources to find out if maybe there's something else I should do. But there's a lot of peace of mind in that. So I think where the error is, though, is that in fact, that fragmented system doesn't ration care more than other systems. It rations care less than other systems for a whole bunch of reasons, including the fact that the incentives of the government and the national system or the insurer, because some of them have private insurers who are working in a highly government regulated market. The incentive in those cases is aligned. They all have decided we're going to cover this and we're not going to cover that. And that's the schedule. But in the US, you have the government's incentive is just to tell insurers they should cover everything, right? Any individual legislator, their incentive is to and this is why, in fact, HMOs became a bad name because they were doing a really good job of cost control and they held down cost growth in the late 90s. And then legislators made them stop and then costs shot up. Which is part of the reason Obamacare was so popular because costs were really rising very quickly after legislators made it harder and harder to deny treatments. And then, of course, patients want treatments. Employers have cross-cutting incentives where on the one hand, they want to hold their premiums down. And on the other hand, when Bob in shipping, his kid has a rare pediatric cancer, no one wants Bob in shipping's kid not to get the best possible coverage, right? And so there's all of these cross-cutting incentives that actually make it much harder for us to control costs than other countries. Although I will say this, we often think about ourselves as having a cost growth problem, and we actually don't anymore. We had a cost growth problem in the 80s in a big way, in the late 90s and early 2000s in a less dramatic way, although still significant. And now costs have roughly stabilized as a percentage of GDP, with the exception of the pandemic. It's a big exception, but that was an emergency event. That's not normal. Our costs aren't growing faster than they are in other countries. We just started from a higher level. We let our costs get out of control like 30 years ago, and we never brought the level of cost down, but we did stabilize the growth.